So we've got Dr. Simpkin. He's a good friend. I call him Jake. And we're just going to really talk about the impact of COVID on us as dentists and how it's changed the way we've been able to do things, what we can actually do. And I really wanted to talk to Jake about this because Jake works in emergency dental services. He works for an NHS practice and he works for a private practice. So he would have experienced how it's affected each of those different areas. So March the 20th, that was when I stopped working at my practice where we work in Penwortham. It's a mixed practice. We stopped March the 20th. And at that point, we were just giving advice, telling people about analgesics, painkillers, and also prescribing antibiotics. So that was my first awareness that we would stop essentially working clinically. How did you hear the news, Jake, and what happened?
Okay, heard the news through the news, and then what happened? I think it's easier to just start with a simple one. Mm-hmm. The private practice, we remained open for maybe a week before the decision was made to down tools, and that was a complete downing of tools, as the government and the powers that be had no contingency for private practices, no help, no support. Mm. So the principal, he manned the phone, basically had a practice phone diverted to his mobile so he could give advice, antibiotics like you touched on, but wasn't allowed to see people face to face. So I temporarily lost that job, I should say. The position's there when I'm allowed to be there. But since March,
so I think people might not fully realize the gravity of the situation. When you say as a private practice, the clinical work stopped, what does that actually mean for the private practice?
Oh, okay. So, so a lot of the NHS practices were able, or the government supported them in the sense that they would give them, depending on what was negotiable, but something like 90% of their contract value. So again, without boring you about how NHS practices get their money, they're basically allocated a pot of money or value of money, and from that they got to deliver their services. So after March, that value was decreased ever so slightly. When the practice was deemed, again, if you were allowed to be allocated a cold hub, you could see patients, but what you could offer them was limited. So you basically to extractions, but you could see them, and the practices were getting paid. So the staff, receptionists, nurses, etc., were also getting paid as long as they were making themselves available to do some sort of work, whether that be on the phone, cleaning, or seeing patients. The opposite was the case of private practices, because they don't get any money from outside, they don't get any government help or anything. Their money is purely from patient coming in, needing or wanting work, and then paying for that work. When that call came through that they weren't allowed to see patients, there was no income for them. There was no revenue. I don't know of any dentists. Oh, that's a lie. I know of one person who was trying to charge for their advice on the phone. That certainly wasn't my practice. That wasn't my principle. He was giving his advice freely and writing prescriptions freely for people, but wasn't allowed to see them. And as a knock-on effect, he furloughed the staff, the nurses. But for me, there was no work there, so I kind of lost that position for now until June. Or when he's allowed to reopen and things. So that's not good. So there's a lot of private practices are probably going to be struggling, and a lot of private associates who will be struggling.
So essentially for a dentist like yourself, you were doing a few days a week there, but if you were doing 5 days a week, let's say, that would have meant that you've got zero coming in, but I'd have been bills to pay.
Yeah, I personally would have been in a lot of trouble. Last year I bought my first house, borrowed a considerable sum of money to renovate it. That's still going on. unfortunately just bought myself a car just before March. So I had quite a lot of outgoings, and if I'd have lost my only incoming, I don't know what I'd have done. And the government help and support that was available was almost nothing. Fortunately, they changed some of their guidelines. I was able to claim some money back, but not if I'd have lost all my income, I'd have been in quite a bit of trouble.
Yeah.
So, there will have been people like that. Not just dentists, a lot of self-employed people as well, as who've lost their income, and the government support has not been. It's not been comparable to that of employed people.
And then
I think these. Sorry, go on.
So the NHS practice that you're at, how did that affect things when the news came?
Okay, so one of the principals, there's a large practice with partners there, but one of the principals kind of saw what was going to happen before it happened. So he was very proactive. So he came in, basically shut the practice down that day. Basically, before it became a thing, became what was later known as a cold hub. So he spoke to the powers that be about his plan, which was to treat emergencies only. So as with other practices, antibiotics, phone advice, and seeing people. But this was before that was deemed a thing. So he basically said, I will continue to see people, not just my own patients. I will open the doors to all patients. They will be vetted for symptoms, and if they are showing symptoms, they won't be allowed in the building. They'll be offered advice or sent elsewhere. And he was able to negotiate a contract value to be delivered, so he could maintain all of his staff at the same level of pay as what they'd be used to. And then a few weeks after he'd done that, that actually became a model, like a functional model, which other practices put into place. They were deemed what we call cold hubs. So they're for people who have no COVID symptoms, and they're offering face-to-face services, but not using what we call AGP, so anything that creates an aerosol or a spray. So treatments were very limited, basically to extractions to get people out of pain, and that was it. Not through our choice, but just through what we were told we were not allowed to do.
So yeah, actually, talk a bit more on that. So how were the protocols different when you're working?
Well, to begin with, we were very much on our own at that practice, because I guess the dentist I'm talking about, he's got a lot of experience. He's worked in hospitals. He's a deputy dean and things. So he had a lot of experience, and he came up with his own operating procedure, which again happened to become pretty much the nationwide standard. We had to come up with our own SOP for patient movement through the building. So it was very limited. It was a very large building. We had 2 separate waiting rooms. So we tried to limit it to no more than 2 patients in the building at a time. Time between them to wipe down everything. And we were lucky because we've got an oral surgeon contract there, so we've got oral surgeons there. So the decision was made to avoid creating surgical extractions. Patients would come in, they would see a normal dentist, and he or she would diagnose and treat if they felt comfortable. But if they were at any point unsure that extraction was going to be smooth, the oral surgeon would be in the building at the time to see them, because they're less likely to create an actual MOS style extraction. So all reducing the possibility of ever picking up a drill. And again, trying to reduce the time that the patient's in the chair. The oral surgeons are fantastic at taking the teeth out, whereas if it was me, I was getting into difficulty, it might take longer. So limited time, patients in the chair, basically. And then that became kind of filtered down from the powers that be for other practices like your own, I assume, and that became the norm. Less patients in the building, time between patients, more thorough. When I say more thorough cleaning areas after every patient ordinarily wouldn't be. So handrails on the stairs, every door handle, pretty much everywhere. Patients weren't to wait in reception; they were to wait outside the building. You weren't allowed an escort unless you were disabled or a child. It was all minimal footfall and trying to be as efficient as you can with the treatment.
Could you give a rough idea of how reduced the capacity was. So how many patients normally would the practice see a day before COVID? And then how many did it reduce down to? A percentage maybe? Or...
Okay, well, during COVID, there was a lot more phone calling for triaging and trying to help people with antibiotics or reassurance before they were seen. So people still busy, but in terms of actual people in the building, patients actually seen. That practice, there's usually there's 14 dentists that work there, but usually about 10 or 12 in at any time, plus a hygienist, each seeing anywhere between 20 and 30 a day. So maybe 400 or 500 people coming through that building on a day, down to maybe 30, 40.
Wow.
The staff weren't all in. We were, and we still are, kind of rotated. So, because I did 3 days a week, I was in once a week. If you're doing 5 days, it might be once a week or twice a week. So they tried to keep the time you're in there as similar as it would have been. And the logic behind staggering the staff was, one, you wouldn't be needed, but also if someone did happen to become ill and everyone had to isolate, you would still have another line of staff to bring in, and actually another line after that in this practice. So it was quite well thought out in that sense.
No, it looks like you guys were really well drilled for the size of practice.
Yeah, like I say, the gentleman in charge, the gentleman who I met at university and you met, he was very on the ball. Before any guidance of the kind came out, he kind of came up with his own plan, and everyone respected and listened to him. And it was like you say, it became pretty much the model that we all had to follow in the future.
That's good. How about the emergency dental services? How did that change? So you worked pre-COVID. You were working at a private practice, an NHS practice, and you also helped out with the emergency dental services in the Blackpool area. So how did that change, transform, stop, or did anything happen to that?
Yeah, I mean, it's fine. It evolved a lot. It grew and changed. I went through huge changes over the time because the two ladies that kind of run the service, they've been dental nurses but not dentists. So the model changed because they asked us as clinicians what we thought would help and improve things. So almost daily emails were sent out, right, this is the bit we want to work on today. What's your guys' collective input? And then we'll trial it. So pre-COVID, the system was very simple. You went through, you phoned the number as a patient in need, and you were triaged by a non-clinical person in a call handling centre. They went through a script. There was always a nurse there in case there was something that they weren't sure about. And they were booked into a clinic later in that day. So as a dentist, I would just arrive there. Appointments 20 minutes long. Typical week day shift is 6 till 9. And I'd just turn up. My book would be full. I'd just work through that list. People could be in the waiting room. Often were in the waiting room. There's very little in the way of extra precautions in that sense. All the decontamination stuff was the same, but patient management, you just sit in your chair waiting to be seen, basically. With a rough time allocation. You had your appointment times, but often the patients arrive early and try and get seen earlier. What they moved to initially was, less time between patients. Sorry, more time between patients. Trying to distance them in the waiting room. And then the final model, which we're on now, we ended up with screens, different PPE. We moved to a model where I would turn up at 6 and then try and phone triage and book people in. That was very inefficient. And what we've got now is, I'm going there later, I'm going there at 3 o'clock today. They now have a dentist as part of the phone team in the office. So they still go through what I call lay people, so the normal boys and girls that normally man the phones. And then if it's deemed appropriate, they're then booked into my book to phone triage, and then I book them into a clinic or can give them antibiotics or whatever there and then. So now when you get to the hub where you're now treated, there are no patients in the waiting room. There's a lot more time. So there's never more than one patient in there at all. treatment there has not really changed because we don't do fillings and things there. It is either taking the nerve out of the tooth to get them out of pain or taking the tooth out. Very, very few fillings are actually done there. So the need for drilling is actually quite low anyway. So in terms of the actual treatment, yes, we did do our temporary filling, and yes, we did take nerves out of teeth to get people out of pain, but majority was extractions, and that's all it is now, basically.
Yeah.
So we see less people. The systems for the patients, it's probably longer winded because they're going through multiple phone calls and things. So, and they can be unlucky because obviously clinic fills up. So they could have waited an hour or so on the phone to get to me before I say, yes, I'll book you in this evening, no worries. But then if you're the next person in the line, oh, sorry, there's no clinic, you'll have to go through that again tomorrow. But that's the case anyway. It's just,
how were people accessing these services? So, okay, so for the private practice, they still rang the private practice as normal, but it was advice given over the phone. For the NHS practice, I'm assuming that they still rang, or did they have to go through another place to then be redirected to the NHS practice?
Oh, the NHS practice, my normal NHS practice, the patient could ring there. Obviously, our own patient could ring us normally. Our number was kind of disseminated across the local practices, and we were taking referrals of their patients. Because again, we were one of the first to be a cold hub. So a lot of the local practices, so if you were local Arnold and you were limited to just giving advice, your advice could be, well, here's a number for King Street, and you can go down there, or you can phone them with a view to potentially being seen there.
Okay, so the NHS practice was seeing their own patients for emergencies, but you also had other dental practices that would refer to that NHS practice to see people.
Yeah.
Okay.
Yeah. And we were quite lucky because it's a long-standing practice, and we have what's known as a tier 2 contract. We have a lot of the oral surgeons there, and that was quite a big thing because, again, trying to limit what we call aerosols again. Those gentlemen that are doing that are far better than most at taking teeth out, so the chances of it becoming an actual surgical procedure is a lot lower, and the time in the chair is reduced. So like I said, the model we ended up with was really efficient. It would see me, I would x-ray, diagnose, either treat there, and then if it was something I was 100% sure I could, or the oral surgeon would take that tooth out once he knew exactly where it was. I hadn't done them all, so it couldn't be any more efficient.
That's good. And the emergency dental service where you were working as well, how did people reach that?
The same as they always have. So 111 can redirect that way. They do have their own dedicated phone line. So the access to that was the same. Okay. And again, practices that were, say, shut at weekends would often leave that number on their answering machine, as well as working there. I picked up more shifts there. So like I said, some office-based shifts like I'm doing today on the phones, which is different for me. It keeps me busy because Thursdays and Fridays are the days that I would be at the private practice, but I haven't been. And again, it's good to see that side of it. So it's a bit different to when you're giving the advice from your own practice. You're actually triaging people that aren't your patient, aren't you? You know, and getting a little bit of insight as to what some of the call handlers have to go through. Yeah. Because some patients can be quite rude, and they're not registered patients. You know, most are very grateful. Most are extremely grateful, but some of the things the boys and girls that are on the phones have to deal with is quite surprising, considering they're only trying to help. You know, they've got to go through that script. I don't have to go through a particular script. By the time they get to me, they've kind of gone through all that.
So talk us through how your week routine would have changed. So before, how many people you doing at each place, and then now, what's it roughly like?
Okay, so before this, Monday, Tuesday, Wednesday, I was at my large NHS practice doing all treatments, so lots and lots of fillings, lots of extractions, lots of denture work, occasional crown, bridge and endo, but not much. As I touched on before, I'm in a high need area, very, very neglected dentition. So not many of my new patients' teeth are savable, shall we say. And then usually I like to do Monday and Wednesday evenings at the emergency clinic when times were normal. Thursday and Friday I was at my private practice where I would do more of my endo work, crowns, bridges, simple orthodontic work. And then weekends I try to do one Saturday a week at the emergency. Sorry, one Saturday a month at the emergency place. And the rest of the time, try to do it at my house and
You pretty much picked up all the days, so that's 6 days, of intense dentistry. Okay, and then how have things changed now?
Well, now I do one day, which is usually Wednesday, at my NHS practice. I do nothing at my private practice, and then 2 or 3 days a week, which aren't full days, doing the emergency based service thing. So this evening I'm doing 3 till 9 o'clock on the phone. Yesterday I did 3 till 8 o'clock. Day before that was in clinic, 6 till 9. So I'm just trying to fill my time up a little bit. I've been doing up the house and the garden and things, but
yeah. I've been doing roughly a day and a half a week, and I think the hardest thing has been making sure I know when I'm actually in work and not missing that.
that day. Knowing what day it is. Yeah, I think that's been quite hard. And again, I've been doing it because I've lost the money from the private place, and some people will have contingency plans, but I was keen to get my first house and then decorate and considerable structural changes and things. So I need some income to help cover myself.
Yeah. And then the news, we recently heard the news yesterday that on the 8th of June, practices will be opening. What has that meant, for you? Are you clearer on what that looks like now, or?
No. I think, risk of sticking my neck out of it, I think it was disappointing to learn that news from the BBC and not be told by the Chief Dental Officer in advance that would be kind of announced. The advice and procedures offered to kind of guide people into work again have been very vague. I think people have basically been told to take reasonable decisions and reasonable precautions themselves and see how it goes. I don't think it's the most clear, and it could be interpreted lots of different ways by different practitioners. I think, again, I'm not quoting anybody or anything, but I imagine a lot of private dental practices will be quite keen to try and go back to as normal a service as possible. One, because they've not been given any funding or help, but two, their patients, they might have been going through some quite complex treatments, implants, etc., and be left kind of just in the middle of that. So I imagine a lot of the private dentists will be trying to operate as normal as possible, making their own precautions, whether that be additional PPE, limited patient interactions, etc. My understanding from this morning's conversations with my NHS staff and things, we're going to be basically initially continuing emergency-based services, but just for our own patients, with a view to perhaps taking nerves out of teeth to begin with, and then slowly expanding that back towards whatever normal will become.
It's like a phased approach.
I think that's what's going to happen. I mean, again, I can't speak for all practices, and a lot of it will determine when our kind of other dental colleagues open, so lab-based services open, because to do crown and bridge work, you need your lab. To do your dentures, you need your lab. So do your implant restoration, you need your lab. So there's a lot of services. We'll have to see when they open and become normal again, and what policy procedures they want to kind of put in place. So I imagine a slow, staged return, additional PPE, reduced footfall, and then as and when things become normal, I don't know. I can't see the emergencies only and having an hour between patients if you've used a drill and things being ongoing forever. Because you've had
what would you say are some
backlog of patients.
what would you say are some opportunities or things that have come up which could be used for the good in the future? So, for example, one thing that we started to get patients to do was to now take pictures, so that we could actually visually see their issue, and would put that on their profile, on our software. So that's actually something that we could just use going forward, where if a patient's got an issue, they can take a picture, and then before we've even met the patient, we've got a good idea of what's happening. Are there any things that you've seen which we could use going forward?
Yeah, I mean, perhaps not that relevant for normal practice, because you're going to get that patient down most of the time anyway, or they're already coming. But the emergency stuff on the call handling side, the dentist call handling side, we have the option to receive video and pictures. That was introduced this week, and that helps from triaging the patients that haven't got a dentist, and that the call handlers might be, especially when it's things. I mean, I wish it was in place. A couple of weeks ago, I was talking to a young lady, and she had what sounded potentially like a cancerous lesion in her mouth, on the floor of her mouth.
Okay.
That would be really good to get eyes on that before triaging them. It'll help make my decision as to where to send her. But I mean, she got seen and everything. I did prioritise her to be seen face to face. But it could have saved a bit of time, or perhaps maybe not being seen, because patients' description of what's going on isn't always what's going on. And actually being able to see it does help. I think for the emergency side of it, it could be good. But again, a lot of it's down to funding, because at the moment they've been given extra funding, so they've got a dentist in the office now. They've got more nurses in the office now, helping with the phone calls and things.
Yeah.
When normal practices can see people again, I don't know if they'd be able to maintain that level of staffing. I don't know. I don't know if UDAs will become a thing. I know for the next few months at least, it's looking as though NHS practices will receive continuing funds, even though they won't be targeted for UDAs. But how long will that go on for? I don't know. It might be an opportunity to change UDAs. I don't think many dentists are particularly pleased with the UDA system. I don't know. I don't know what would happen with that.
Maybe 6 months, 12 months down will be a lot more clearer about how things are going with dentistry. But I like to think that there's good times coming, and that there's some changes that are going to happen which we can use for the better. I just like to look at it from an optimistic point of view.
Yeah, I don't know. I think private dentistry won't change much. I think they will be able to source the PPE when things have calmed down and spend that extra bit of money and things. And although it sounds perhaps not the greatest, some of that cost can be passed along to the patients. I know that's not the nicest thing to say, but the worrying thing from an NHS practice, if they are forced to have additional PPE and procedures and things in place, the NHS practice don't set fees, so some of them will run into a negative and will close. So, I mean, again, it depends how much you're already aware of, but a lot of dental practices don't actually generate that much revenue or that much profit anyway, and rely on private income to kind of bump that up. So if you increase the cost of an NHS running practice, you might end up with some closing because they deem it not to be worthwhile anymore, which would negatively impact patients. Obviously, we already don't have enough practices in my area anyway. And then, and like I've already spoke about earlier in our conversation, a lot of my patients could not access private dental care, even if they wanted to, and that would be a real shame.
Hopefully there'll be a resolution to that. because yeah, NHS practices do help a lot of people in dire need that would otherwise have no access to dental services. So we can't let that go, forgotten.
Yeah, but anyway, I mean, I like you. I like to try and be a bit more positive. Personally, but from a completely personal point, in 6 months' time, things would become pretty much normal, because I don't know. I don't want to say too much, but I imagine, like with previous pandemics and previous health concerns, it will kind of become. It will either slowly phase out, or it will remain in population, but at a level which isn't a significant risk to people as a whole. Similar, I guess, to when HIV became apparent. Everyone really panicked about how this was going to affect health services and things, and obviously it did create change. Policies did change, but the overall service didn't change after a period of adjustment. It's no longer the case that person has to be seen at a particular point or not seen. They're treated just the same as everybody else, and the service provided has gone on pretty much unchanged. I imagine it will be something like that.
Yeah. Dental practices are very safe places already to begin with. So I think I share a similar view there.
Yeah, I mean, I'm pretty confident that a dental practice is probably got the highest standards of decontamination procedures in place of all medical settings, and quite rigorously vetted by the CQC. I think it'd be hard pushed to find another medical setting outside of perhaps an actual theatre, whereby safety in terms of decontamination and cross-infection is adhered to as well as in a dental setting.
Yeah.
So I think with minimal adjustments, it would still be a pretty safe place to go and be treated.
That's good. Now, thank you for that. Thank you for this video and the other video. If you haven't seen the other video, Jake told us his dental journey. So go check that out. Until we see you in the next video.